Joys and fears, they're all tied up as memories and are probably amongst our most conscious thoughts as humans. But how are these thoughts and linked emotions made and stored in the brain as memories? And why do they overtake or forsake us at times? For instance, when fear grips, memory often leaves the room. And are fears part of the memory wiring and storage, or are they totally different in terms of neurology and psychology? Pankaj, as our resident all-rounder in all things neuroscience, what exactly are memories and fears, and how are they formed and stored in the brain, and why do we need them in the first place?
Look, fear memories are very ancient, and they arose to allow us to survive in dangerous situations. And, you can imagine we were wandering around the savannah and maybe drinking from a pond regularly. And one day you go along and you get attacked, or there's a predator there, and you need to be able to react to that immediately for a start. Next, you can't be coming back the next day and hoping things will be just the same and hoping you'll recognize the predator again. So you need to lay down these memories and be able to respond to them very quickly. So this system arose for us to survive and respond very quickly. So fear memories are really a way for us to respond to dangerous situations and be able to lay these down and recover them very quickly. And the circuits that underpin this, of course, are present in us, and they're present in small animals as well. And this very preserved, and they engage the regions of the brain, particularly the amygdala, which is a small part of the brain, which is named after the Greek for almond. That looks a bit like the almond if you cut sections of the brain. And the hippocampus, where memories are stored, and the prefrontal cortex, of course, which is a large part of our brain. So these systems are pretty much conserved across many, many species. And even in today's world, what it's there for is to help us survive in a dangerous world.
And take us on a journey through the brain as we experience something new and then we make it into a memory. What happens?
So when you have a new event, when you experience something new, so your analysis of it, depends on a couple of things. Firstly, what your immediate response to it right now is. So if it's a painful stimulus, you'll have pain. But then there's memories from your past, and you bring those up and see where that fits into the world, and also whether it's dangerous or not. So, you may be listening to a nice concert and it's a happy event, and those things get laid down as well. But anything that has an emotional response to it, which creates, so classically things like weddings, funerals, why do we remember 9/11 so well? It's because you have a big emotional response to it. And what's thought to happen, I should say, is that there's a phenomenon called plasticity, and it's supposed to initiate for fear memories. It initiates in the amygdala, where something changes, and what changes is that patterns of connections within the amygdala, and these patterns then get stored down in the long term. And what happens is some genetic changes take place as well. So this memory is formed and it's stored there. And the idea is that next time you experience an event which is similar to that event that you had, then the whole memory comes back. And I'm sure many of you have experienced this before. You'll hear a few bars of a song which you were very excited with when you were 16. Haven't heard this for 20, 30 years. You hear the first few bars, the whole thing comes back because it raises all those emotions that you once had, and all comes flooding back. And that's how memory systems work.
So how does the brain know when to shift the memories to an archive, to a long-term storage? Or do we actively reconstruct an event every time we engage in a memory retrieval?
Well, we don't really know when the brain decides. It seems from what we know about memories are formed and they're short-lived. And then over time, they undergo a process called consolidation, which might be overnight or a couple of days. But what determines which memories get stored and which don't, we don't really know that very well. But what's pretty clear, though, is anything which has a strong emotional response are more likely to be stored.
Muireann, your work at the Brain and Mind Centre at the University of Sydney seems to straddle the worlds of basic and clinical neuroscience. Can you tell us about the two strands of your research, and both which are centred exactly on how the brain remembers pivotal events?
Absolutely. So one of the things that we're most interested in is how we actively reconstruct pivotal events from the past. And these are often emotionally imbued, they're visually rich, they have a lot of sensory and perceptual detail, and they allow you to actually vividly and mentally relive key events from your past. So this could be your first day at school, your wedding day, birth of a child. And so, as Pankaj just said, they're very emotionally salient events, and we re-experience them visually in our mind's eye. And so the underlying circuitry of this within the brain is incredibly complex, and we're only beginning to sort of scratch the surface of how this recollective endeavor is supported. And so that's one aspect of my research where we're really trying to understand how memories are relived and sort of constructed, but also how memory may form the foundation to enable us to travel forwards in time and actually envisage or imagine the future. And so again, this is a constructive process whereby we draw upon details that we've actually experienced in the past, and we can then flexibly recombine them to envisage events that have not yet happened. And this, from an evolutionary perspective, would be highly adaptive, because it means that you can actually anticipate, respond to, and maybe alter your behavior according to events that you haven't necessarily experienced. And so in parallel with this work, we're actually exploring how these processes then become compromised in dementia syndromes. And so on this image here, we're looking at how impairments for remembering the past actually are paralleled by a deficit in being able to envisage the future. So not only are our patients with dementia experiencing profound memory loss for some of the most key and pivotal events from their lives, but they're actually unable to anticipate what might occur or what might unfold even next week, tomorrow, or into the far future. And we're elucidating now what the neural substrates or the neural regions that are responsible for these deficits are, using different forms of neuroimaging. So we're trying to use basic neuroscience in parallel with some of the clinical aspects to really inform our understanding of the brain, and also to try and get a better capture or better insights into the experience of the individual living with dementia.
And related to that, you're also looking at the role of imagery and spatial integration in daydreaming.
Yeah, so this has been one of the really interesting new avenues that my research team is pursuing. And it's what is happening when we're idle or seemingly not engaged in an active or concurrent task. And so for many of us, if the external environment is not engaging enough, what we can do is actually activate a very complex network in the brain called the default mode network. And this allows us to actually transport ourselves out of the immediate situation, to daydream, to reminisce, to plan, and to be creative, or to engage in flights of fancy. And what our research is actually showing now is that in dementia, these processes are markedly compromised. So our patients are very much stuck on the external environment. And I think that speaks volumes to us in how we actually tailor care to the individual, that the immediate and external environment becomes pivotal, and that we have to make sure that we're actually stimulating from the outside in.
And this research may well inform early intervention to prevent more distressing experience for people with dementia.
Absolutely. I think being able to use sort of non-pharmacologic interventions like music therapy or art therapy, and just being mindful that if you leave an individual with more advanced dementia, they will not be able to spontaneously withdraw from the immediate surroundings and engage in something that's actually quite a luxurious evolutionary sort of sophisticated aspect of cognition that we have, which is to allow our minds to wander.
Kim, can we ask you the hard questions? Just unpack some of the memory terms for us. You know, we hear about new memories, working memory, consolidated, emotional, past memories. How do they all differ?
So, I mean, I think the other speakers have already touched on this to an extent, but what I think the take-home message is, there is not one memory system. There is not one type of memory. Memory is actually, there's multiple memory systems, and they really are, there's not one area in the brain that memory is stored, or one memory centre. It really is a network of different neural structures that are involved in memory. So, again, with memory, we have different stages of memory processes. So, you know, that very new memory is really the sensory impressions. When, you know, you're getting vision coming in of, you know, a green car that's just hitting another one, and that's a very salient thing, then that is going to be stored in your visual system. You know, you may be getting other sensations that are associated with that, and then associated with an emotional response. So that's that very early new memory. Then, you know, for other memories, we might be keeping them in working memory, that is actually when we're actively rehearsing. It might be, an event or an experience or something we need to learn, some knowledge or a word list, a shopping list for me is something I regularly forget. So with working memory, what we're actually doing is actively rehearsing, because our brain actually has limited attentional capacity. So we need to rehearse to keep that active and in mind. As Pankaj was saying before, consolidation processes then start to kick in. We don't know nearly enough about memory consolidation and the mechanisms underlying it as yet. It's certainly a large area of discovery. But again, there's multiple processes involved in memory consolidation, but the idea around memory consolidation is you're strengthening and stabilising the memory so that it actually is then going to be in longer term storage in a distributed network that then can be retrieved. And, another form of consolidation that's really interesting and has got a lot of traction in recent research is memory reconsolidation. And this is speaking to what Muireann was talking about, each time that we're retrieving a memory, we're actually reconstructing the memory. So an early idea was we get a memory, and especially I think around emotional memory or trauma memory, the idea was it was there, it was indelibly printed on your brain, and it was permanent. We actually know now that that's absolutely not the case. Memory is flexible and it's amenable to change, which really gives us a lot of hope for how we can work with memories in some of our clinical disorders. So the idea of memory reconsolidation is that when you get a retrieval cue, you actually bring this memory back, but it's in a labile state again, which means that it's plastic. It can actually be changed depending on what other things are in the environment at that time.
So every person's memories and fears are unique to them, and even disorders that involve memories and fears seem almost intangible and ill-defined with each one on a personal journey. At such times, what we most treasure could develop into our worst enemy. So let's find out about the scary flip side of good times and great memories. Kim, your specialty is, as a clinical psychologist and neuroscientist, is in the very tough area of post-traumatic stress disorder, PTSD, which sadly we hear too much of these days from all quarters. Could you tell us how memories and fears interact with PTSD sufferers, and what does your research aim to achieve in this space?
So I think fear and memory are the two integral mechanisms within PTSD, absolutely. And we look at a patient's symptoms, and one of the most distressing symptoms is getting these really distressive, intrusive memories popping into someone's mind that people are trying to understandably block and push out. Also with PTSD, there's a characteristic fear response, and typically it arises when there's trauma reminders because it's a conditioned fear response. So these work together, because what we think is that, say you've had a trauma where you have had a car accident in a green car. Now, you've never been scared of a green car before in your life, but at the time of the trauma, your life is threatened. What we think is happening there is you get a massive release of noradrenaline and cortisol, these stress hormones, and animal research and human research does implicate the release of stress hormones within the amygdala in terms of emotional memory consolidation, in terms of strengthening these memories. So one area of my research is actually we're getting people to be looking at different images, negative and very emotional images, and we're measuring the level of their noradrenaline and cortisol and seeing how it impacts on their subsequent memory. And another area is this fear conditioning process. So you've never been scared of a green car before, but at the time of the trauma, with that intense fear response that you have, that becomes associated with that shade of green. Now, that's often on an unconscious process. You're not consciously aware of that. But because of that fear conditioning, again, which is implicated in the amygdala, when you then confront that colour green in the environment, when the accident is over and you're perfectly safe, bang, you get that conditioning conditioned fear response back because of the activation of these subconscious networks in the brain involving the amygdala. So, the scary thing is about 70% of us will actually have a trauma at some stage in our life that may involve life threat. But only 10% of us develop PTSD, so that's a good news story. And so we think it's not just fear conditioning, it's actually what we think is happening with PTSD is a difficulty in extinguishing the fear. So if you're going around in the environment seeing the shade of green and nothing bad happens to you, normally, gradually over time, your fear response starts to come down. Your amygdala response starts to come down. But we think that for people who go on to develop PTSD, this process for some reason is impaired. And so that's another area that I'm looking at, is looking at fear extinction and fear conditioning in PTSD. And this actually works together with the intrusive memories, because if you get a trauma reminder, if you then have a conditioned fear response, that triggers an intrusive memory of the trauma. So they're really integrated.
So, Muireann, how much do we know about what is going on in the brain with an individual with Alzheimer's disease or other dementia conditions? What are the major advances, say, in the last 5 or 10 years to help us understand that?
Well, certainly the development and sort of refinement of neuroimaging techniques now permits us to look into the brain of the individual with dementia in vivo, so we can actually look in life to see what regions are activating, where the structural and functional damage is occurring. And so what we can do is actually ask the patient just to simply lie quietly in the neuroimaging scanner. They don't have to complete a task. And so we can look at the extent of grey matter atrophy. That's these different structures in the brain. Here we're looking at an Alzheimer's brain from someone who's participated in our research. And we can identify actually relative then to aged match healthy older individuals where the key regions of brain atrophy are occurring. Now we can also track to see where's the damage between grey matter regions. So these are the sort of highways or the pathways of the brain in terms of white matter. And we can look at connectivity and how different relay stations across different structural networks are compromised in dementia. And also we can use functional connectivity approaches to look at how regions are actually talking in real time to each other and where metabolism is compromised. And I think one of the most exciting aspects of these imaging developments really is looking at the phenomenon of amyloid deposition in the brain. And so it's become much easier now for clinicians and researchers to identify individuals who are actually in preclinical stages of dementia, who are vulnerable to possibly developing dementia, simply by looking at where amyloid deposition is taking place in the brain. And I think this has huge implications for early diagnostic and prognostic attempts to really identify who is vulnerable and how can we intervene in a much more meaningful way.
Because probably by the time you start seeing people, they're well and truly advanced, and the key is to really get in early for better interventions.
Unfortunately, by the time most individuals will present to a dementia clinic or a memory clinic, the underlying atrophy and the underlying pathology is actually taken hold. It's encroached into too many regions. And so ideally what we would need is to identify people who are in a preclinical or prodromal phase of dementia, to get them onto the appropriate therapeutics and to hopefully halt and give them improved quality of life for much longer than we can with the established clinical diagnosis.
Another area that we're hearing more and more about these days is the role of music, the powerful role of music in cueing and facilitating memory retrieval.
Yeah, I think this is a really fascinating area, actually, because universally, music is actually a language that we can all speak. And so it becomes a very attractive non-pharmacological way of communicating with patients, even when verbal capacity and fluency and the ability to communicate through words or through language has actually been compromised. And so one of the first studies that I ever did was motivated actually by my grandmother having Alzheimer's disease. And I really wanted to do something practical that might help, ameliorate some of her distress. And we ran a study looking at using Vivaldi's Four Seasons, so the spring movement from that, and found that when we counterbalanced across conditions, memory retrieval was actually markedly improved when our Alzheimer's patients were recalling during the music condition. And this couldn't be explained by a practice effect or by the the music coming first or second because we counterbalanced across. And we ran a number of other studies to try and tease out what mechanisms could potentially be driving this effect. And it turns out that it was a very simple effect of calming and actually reducing state anxiety. And so the individuals were coming in quite agitated and concerned about their memories, and just simply being in a more soothing and conducive environment to retrieval actually really helped them to remember these pivotal events.
And music being emotional highlights the role that emotion plays.
Yeah, and the fact that as well, music is in itself inherently rewarding. And we know that in Alzheimer's disease, many of the reward pathways actually remain relatively intact until much further along in the disease trajectory. So it actually offers a very attractive sort of pathway that you can target using other sort of non-conventional stimuli like music and art, that you can work on the premise that these individuals can respond to these rewarding stimuli and actually offer them some sort of a boost in arousal and emotional quality.
And interestingly, playing music to people who would listen to music like we all do very passionately when we're in our adolescence and teenage years, that music can be extra powerful for those later in life.
So there's a phenomenon in autobiographical memory research called the reminiscence bump. And this speaks to the fact that most of the defining memories that we have come from our early adulthood period. And it makes sense in terms of your identity and experiencing events that actually start to define who you are, like your first date and, graduating from college, getting married. And so the music from those particular epochs in an individual's life could be particularly powerful and particularly rewarding for the individual and cue specific events. So like your wedding day, you may have had a specific song that you danced to with your partner. And so now people are starting to look at individualized approaches to use a more person-centered approach to really probe using music that's meaningful and personally relevant for the individual. And I think that's going to have much more tangible effects as well.
Pankaj, what diseases and disorders of our memory circuits and pathways are being targeted at your research institute? And can you discuss some of the key mechanisms that are coming to light as possible target for intervention?
Well, look, quite a bit of the institute works on these memory type circuits, and again, using the amygdala and hippocampus and looking at the circuits there. And PTSD and anxiety type disorders these are the circuits that they're engaged in. So how do you go about treating these disorders? Right? It's an interesting question to think about. And one option is you go down a clinical track in the sense that you have things like music therapy, if you like. The other option is pharmacological. And, a good example of this is benzodiazepines like Valium, which usually people use to put them to sleep, but also it's a fantastic anxiolytic. And often, if you go and have severe anxiety, one of the first-line treatments is using something like Valium. Now, so what does Valium do, right? So what we know is it works at particular compounds in the brain. So it works at receptors that we know about. So one of the things that we're trying to do is look, so Valium, you might say, is a great anxiolytic, but you take a bit of Valium, now you're not supposed to drive. If you take enough of it, it gets you drowsy, puts you to sleep. So the reason it does that, because it has wide-ranging effects throughout the brain. So one possibility of doing this is let's find the exact circuits that are involved in anxiety. Let's call them the amygdala hippocampus circuits and say, look, maybe the proteins involved there are different. And we are finding some differences in those circuits. So you look very carefully, now you can start designing compounds which will only work at those specific circuits and ignores the rest, okay? So one way of going about it is looking at specific therapy, and the kinds of things we can work with on anxiety disorders is one of them. So in the Institute, of course, we have quite a range of disorders we work on. Another one is motor neuron disease, which is cells are dying in motor neuron disease. And models for working with motor neuron disease, they come from all sorts of places. Now, one of the things that our institute has done is, we are not species-specific, if you like, or species-centric. So we have people who work on worms, people who work on small animals, as well as bumblebees and people. And it comes from the fact that, we know so little about the nervous system that, why ignore what's happening in a bug, and maybe findings from the bug will go all the way to people. And one of the things that's coming out of this kind of research is mechanisms to fix dead cells. All right? So a lot of the studies that were done by Perry Bartlett, in fact, who was the founding director of the QBI, was looking at a compound called EPH4, which was involved in regeneration. Now, they were studying how cells get from A to B, and it turns out you can use these same compounds to try and treat things when cells are dying in motor neuron disease. So we're about to start a trial using a drug targeting this system used to treat motor neuron disease, which is a long way from development. But the other area is, we've found a compound which fixes damaged neurons in a C. elegans, and C. elegans is a very small worm, and many of you would probably never have seen one. But what's interesting about this animal is we know exactly about all the cells in this animal. There's about 1,200 cells. We know exactly which one everyone is. It's got very different to us, many billions of cells, and we know very little about them. But we've identified, if you cut the cell axons in there, that's the nerve fibers, you can find how these things heal. And again, this is going from there to looking to see how you can treat injury to nerves. So these are the kinds of areas that we're looking at. And more recently, of course, we've been looking at dementia, trying to think about the mechanisms for treating dementia.
RN's Lynne Malcolm peering into the recesses of the mind with Pankaj Sah, Kim Felmingham and Muireann Irish.
On RN, this is Big Ideas with Kathy Van Extel. You can listen back to plenty of other big ideas online or on the ABC Listen app.
The prospect of your mind failing you and losing touch with reality is terrifying. The fear of losing control. More than 400,000 Australians have dementia. Every day, around 250 people are told that they have it. Without a medical breakthrough, those numbers are forecast to more than double within 40 years. The costs of dementia are huge, both human and economic. It's the second leading cause of death. It's the greatest cause of disability in Australians aged over 65, and there's still so much to be learnt about the causes, let alone the treatment and the best care options. The good news, though, is that progress is being made. Pankaj Sah explains the work that the Queensland Brain Institute is doing in this area.
Dementia is a progressive disorder, and it involves two proteins. There's one called A-beta and tau. These are the plaques you hear about. And both these interact with each other. Now, a lot of the drugs that have been designed, so the idea was how do you treat oncoming Alzheimer's disease? Well, let's stop plaque being laid down in the first place, and maybe that'll be a way to go about it. Now, you design a compound which does this, and how do you put it in there? Well, one option is to drill a hole in the head, put an electrode down there and inject it. Now, obviously, you can't do this to whole populations, right? I mean, maybe some people, but not everyone. Now, alternatively, you take it orally, which is the way we do most drugs, or inject it into the bloodstream. And that's fine. And, this is how we fix all sorts of disorders. Now, the brain is a protected environment. There's a thing called a blood-brain barrier. And this stops things going from the bloodstream into the brain. And the reason a lot of drugs don't work, they work in a dish. You put it into animals, and it just never gets there. Something like 98% of the compounds that have been tried just never make it into the brain. Or the amount that makes it in is very small. So Jürgen Goetz, who's the director of our Dementia Institute at the QBI, was trying to find a way to open the blood-brain barrier. Now, what you can't do is simply go in there with a brush, for instance, and open it up, because then you get bleeding into the brain, something you don't want. So he was using ultrasound to open the blood-brain barrier. And ultrasound is the same ultrasound that's used clinically, for kidney stones, for looking at babies. So his idea was, let's use ultrasound to vibrate these blood-brain barriers, see if you can open it up briefly. And the whole object of the exercise was to introduce compounds into the brain. Well, what came out of this? So this was in mice, okay? And so mice, you might think, do mice get dementia? Well, we can make them get dementia. We can make... the average mouse will live 2 or 3 years. So we make transgenic animals. They are genetically modified animals who do get dementia. They get Alzheimer's disease. So these are the mice we were going to treat with compounds we were making in the QBI. On the control side, of course, we do ultrasound to animals. We don't give them any drugs. And it turned out that opening the blood-brain barrier opened the blood-brain barrier briefly and could clear plaque from these animals. And we actually managed to cure mice which had Alzheimer's disease. Okay, these are mice now. And simply by opening the blood-brain barrier, and what turns out happens is that there's a vacuum system in the brain, the garbage keepers, the microglia, which are cells you don't often hear about. There's a lot of cells in the brain called microglia, and their job is to clear up the debris. And what opening the blood-brain barrier does is activates these microglia, and they go along and clear these plaque. So one of the really interesting things that's come out of this work is using ultrasound to open the blood-brain barrier and treat Alzheimer's disease. Now, you can't simply take an ultrasound device, go from a mouse to a person, mainly because the skull in us is much, much thicker, and ultrasound can't go through a thick skull nearly as easy. You simply can't turn up the amplitude because then you get heating. So what we're trying to do is design a device now which you can take it to persons and do a clinical trial. Now we've done sheep. Again, sheep don't get dementia. Well, maybe they do get dementia. Would you know the difference? Not so sure. But we are treating sheep with ultrasound, and we can certainly open the blood-brain barrier safely in sheep. And the first point of entry into the system is to show that it's safe. We don't want to do any more damage by opening the blood-brain. So in sheep, it's working. And our plan in the next year or so is to take it to a clinical trial in humans, initially starting with a safety trial. The beauty of this system is it's cheap. This ultrasound device will not be very expensive. It'll be portable, and it's quick. We're imagining something that'll sit in a GP surgery, could be taken out to the countryside. People would not have to come to a major hospital to have this delivered. So this is very exciting times for using this kind of treatment. And this is the kind of thing that comes from just having a blue sky idea.
So just carrying on the theme of good news and some of the exciting possibilities in the area of treating humans and the non-pharmacological approaches to treating dementia. I think one of them is direct electrical stimulation. Just tell us briefly about that.
So direct electrical stimulation, there's two ways of doing it, right? So many of you might have heard about Parkinson's disease treatment. This is called deep brain stimulation, and electrodes are placed inside the brain and they stimulate regions of the brain. This is a fairly invasive procedure. But we do treat people in Brisbane here, and we have the Centre for Neuromodulation, which is, again, part of the QBI. Over the last 15 years, we've treated close to 1,000 people. And these are people who are not responding to drugs nearly as well. And you implant electrodes into the brain and stimulate the brain. It's a bit like a pacemaker for the brain, if you like. And this does work very well for Parkinson's. It works very well for people with essential tremor. I don't know, some of you might have met people who have an essential tremor. They're fine at rest, but they try and drink a cup of coffee and their arms are shaking and the coffee goes everywhere, or the tea. Now, we can treat people like this with deep brain stimulation as well. So what about dementia? One of the things that's happening in dementia is circuits are dysfunctional. Same way people in Parkinson's disease, circuits are dysfunctional. So another methodology is to think about deep brain stimulation. Now, neuroscience, putting electrodes into a person's brain is a fairly invasive procedure, requires a major surgical intervention. So are there ways to stimulate the brain without doing the surgery? Indeed, there are. And in animals, models, these are again starting to be developed now. And one of the ways we're headed is thinking about ways to stimulate the brain without having to do the major surgery and using either, again, radiotherapy or long wavelength light. Another interesting region would be light. And people are finding that using light stimulation is helping animal models.
Kim Felmingham, how do researchers actually study fear? And I guess in studying fear, the findings must be so key to your work, yet it's a fraught area, both in practical and ethical terms.
Yeah, so to study PTSD, we need to study patients with PTSD, which is always, therefore, ethics is your main concern. We're not working with animals where we can go and, ultrasound some of the blood-brain barrier or create illusion.
Well, we do care about sheep.
That's right, we do. I'm sure some sheep have PTSD too, from me trying to round them up. But look, I think what we really need so to study fear is actually really complex again. What are our markers of fear? How do we do that? And one of the criticisms we have is we can never actually traumatise someone. We don't want to ethically. So we can never actually recreate the trauma experience in the same intensity in a scanner or in a lab-based procedure as what, people have experienced. However, we still have very good methodologies where we can actually be looking at the mechanisms that we think are involved in PTSD. So we have a fear conditioning and extinction task that we actually use. It's preserved across species. We use it in rodents, we use it in mice, rats, and we have the same procedure in humans. And that way we can study how quickly can people extinguish fear. So that's basically showing people, we attach people to an electric shock, give them a little mild electrical stimulus. We show people coloured circles, either red ones or blue ones. Every time they see a blue one, they get a shock. The red one, they never get a shock to, so it's a safety signal. To track how much conditioned fear they're developing, we actually measure their sympathetic arousal through skin, sweat gland activity in their fingers or their heart rate, and you see it go up to the danger signal, the one that's associated with shock, and the other one doesn't change. Then in the next phase, they are not told that they're not going to get any shocks anymore, but we stop the shock, and we then look at how long does it take for that arousal to come back down. Okay, so that's an extinction phase, and that's the one we're particularly interested in PTSD. We then get people back into the scanner or into the lab the next day, attach the electrodes again, show them the same circles, deliver no shocks, and we see how much has that arousal returned. And that is then looking at memory. How much can they remember that fear extinction learning? Because we think that is particularly compromised in PTSD. Now, what's really exciting is that if we get someone into the scanner, we can see during the acquisition of fear conditioning, the amygdala lights up. During fear extinction, the ventromedial prefrontal cortex is activating. And we know neurobiologically that the ventromedial prefrontal cortex does have an inhibitory input on the amygdala. What do we see in people with PTSD? We see hyperactivity, greater activity in the amygdala. And one of the most robust findings, we've found it in over 90 fMRI studies now, is that there's reduced activation in the ventromedial prefrontal cortex during extinction learning. So we've mapping the neurobiology of these systems, which map nicely onto some of the animal research. What's even more exciting for me as a clinician, we did one study. We actually, the best treatment we have for PTSD is not pharmacotherapy. In fact, people have been trying for 40 years and really we haven't got very far. So it's an area where we really need this animal research informing us. But our best therapy is called exposure therapy. Exposure therapy actually involves going through the memory of the trauma in great detail and over an extended period of time and doing it repetitively, ideally every day, which you can imagine is incredibly difficult for someone with PTSD to do. So we have a fair amount of dropout and we have some people, unfortunately, who have a partial response. However, about 50 to 60% of people, even if they've had PTSD for 30 years, are no longer PTSD or have substantial reduction of symptoms during that time. What is the mechanism of exposure therapy? We actually think it's extinction learning. Mm-hmm. It also involves belief change. I can cope with this memory can no longer harm me. But we know that fear extinction works because they're exposing themselves to the conditioned fear, the memory, but nothing bad happens. And gradually over time, their arousal comes down. So what we did was put people into the scanner before and after they did exposure treatment. And this is a really good news story. What we actually found, and this has been replicated several times now, is that correlating with the amount of symptom change people had after exposure, their amygdala response came down and their ventromedial prefrontal activation increased in PTSD. So what that basically shows us is exposure therapy, when it's working successfully, can actually correct these areas in the brain that are actually dysregulating, so that can actually reduce activation in these fear networks and increase fear extinction networks. So that's really some exciting areas. But, one issue we do have, which we can't ignore, is that about 30% of people don't respond or have a partial response or they relapse afterwards. So we really need to do a lot more work, and this is where my work is heading. How can we augment exposure therapy. I don't think we should throw the baby out with the bathwater and get rid of exposure therapy because it works for 60% of people. But can we identify those people where it's not working as successfully? Can we then facilitate exposure therapy for them? Now, one area we're looking at the moment is a neurotrophin called brain-derived neurotrophic factor. That is actually a neurotrophin in the brain that's actually really involved in synaptic plasticity, and it is involved in learning and memory consolidation, and a lot of animal research is now suggesting it's also involved in fear extinction. We did a study where we looked at a genotype that actually is linked with BDNF function. We found people with PTSD who had a BDNF genotype that had low levels of BDNF had a poorer response to exposure therapy. So now where we're looking is, can we actually increase BDNF, and will that improve response to exposure therapy? And one really good way to increase BDNF is through exercise. So these are some of the areas that we're starting to look at now.
Great. So, Muireann, one of the main drivers of your research was seeing your, as you mentioned, seeing your own grandmother experience Alzheimer's disease. With that in mind, what are the short-term and the long-term outcomes that you hope to see arising from your research?
Well, yeah, I'm sure I'm not in the minority when we speak about personal experience with dementia, because it's a growing concern, and we know that we're sort of poised on the brink of a dementia epidemic in Australia and globally. And so for our family, growing up in Ireland, my grandmother was the ultimate matriarch. She was a real pioneer at the time, and she had established her own midwifery service. And she was basically the local record keeper of all of the children who had been born, their birth weights, complications, the outcomes of delivery, who their mothers and fathers were, the scandals. So she had this, she could tell them all. But she had this phenomenal memory. And so it was like the cruelest irony that her memory was the function that actually was so vulnerable, and it tormented her at the start. So she had a remarkable insight into the fact that her memory was failing her, and yet couldn't understand what she could do about it. And so at that time, I was grappling with this idea as well, and watching someone that I had been so close to not be able to relive or remember any of our shared experiences, and confuse me with my mother. And it was a very fraught time for all of us. And so that did prompt me to want to specialise in understanding the circuitry of memory, and also how fallible it is and how vulnerable our memories are. So in the short term, what I'm hoping that our research could achieve is really to understand or provide a more nuanced sort of approach to actually early diagnosis of dementia conditions. So a lot of the clinical tools that we rely upon are actually not sensitive enough to pick up the subtle early markers of memory change. And so by the time the tests are actually revealing that something might be anomalous, it's actually too late, as we said earlier, and the underlying pathology has really taken hold. And so in the long term, what we would hopefully be able to achieve is that we could track individuals from maybe genetically at risk families, or people who are more likely to be prone to developing early symptoms of cognitive decline, and use tests that could be easily administered, as Pankaj said, in a clinical setting, even by the GP, that would be sensitive then to flag that these individuals should go for more sophisticated neuroimaging or diagnostic workups. While we're waiting, and we're cautiously optimistic about a cure in the, maybe mid to long term, I think we also need to be mindful more about tailoring care towards individuals and providing support for families as well. Because at the moment, there's still, unfortunately, a lot of stigma attached to a diagnosis of dementia. Families tend to withdraw socially and kind of corral the individual, and we need to keep them as active and as engaged in society as we can. And there's a lot of international efforts where we're seeing communities such as in the Netherlands that are pairing, childcare with aged care, and actually trying to bring together, populations that can actually inspire and motivate each other, and just being more strategic and, I think, creative in how we approach dementia care.
Yes, because it is such a a family affair, isn't it, with dementia? As you said, it just affects the whole family and the dynamics, the relationships between everybody.
And I think as well, in tandem with the cognitive decline, there's a whole host of other sort of social factors that we hadn't considered at that time. And one of these is the vulnerability of people who do have cognitive decline to things like financial scamming or abuse or manipulation or coercion. And we know that some of our work on future thinking in dementia means that our patients are actually unable to envisage the outcome of decisions that they're making. And so they can't appreciate perhaps the gravity of giving money to somebody or engaging in risky behaviours. And so we really need to start being more appreciative of how we can protect individuals in the early stages of cognitive decline and also empower them to make decisions about their treatment and their long-term health and care.
There are a number of ethical concerns in this area as well.
Yeah, absolutely. So I think there's a lot tied up with how we identify whether an individual has capacity to make decisions regarding their own well-being and care. And also there's a huge, all of the social and emotional dynamics that come as a part of being a family and who is going to become the power of enduring power of attorney, who's going to take on the financial decision-making on behalf of the individual. And then the decisions about when is the time that you decide to move somebody into care? Is that the best thing for them, to move them from their homes where they have myriad sort of memorabilia that can actually act as memory cues to keep somebody in the home for as long as possible, but also offsetting that with, is it safe to let them live, to continue to live, unaccompanied maybe or on their own. So it's fraught with many sort of medical, legal, financial, emotional implications. And I think we still don't have a good framework for how we deal with that at the point of diagnosis.
All right. I wonder finally if we could get from each of you just a 1 or 2 minute answer, what your burning question is about memories and fears at the cellular or the neural circuitry level that you would love somebody to solve, hopefully you. So, Kim, can we start with you?
Well, I've got about 1,000, but I'll say 2. A few areas fascinating. One golden question is, how do we prevent PTSD? And a lot of people are doing some amazing research in this area, but it actually requires testing people prior to trauma. We need those longitudinal designs. With stress hormones and memory consolidation, one question is, can we reduce stress hormones in the acute aftermath of trauma? Because maybe that will then prevent this greater consolidation of trauma memories. So people have tried propranolol, they've tried other agents. Sadly, nothing's worked as yet. But that's one area that I would absolutely love to be looking at. But other areas are intrusive memories. So it's very hard to actually look at the neurobiology of intrusive memories because by definition, intrusive memories spontaneously come in at random. Maybe they're cued, that's how we try to do them, but to actually capture one of the most distressing symptoms in PTSD of these spontaneous intrusive memories is incredibly difficult. So we do not understand much about the neurobiology there of one of our core symptoms of PTSD. And the final question that fascinates me is we know that women actually develop PTSD at twice the rate men do. Now, we do know that women are experiencing more childhood trauma, interpersonal violence, sexual violence, which are associated with higher rates, but that doesn't explain all of the variants. And we've got some really intriguing evidence now that lower levels of estradiol actually are impair fear extinction learning. What this raises for me is a question very few people actually think of, but we all take them, oral contraceptives, which suppress estradiol. So this is one question we're starting to look at is what is the impact of oral contraceptives on fear learning extinction? Does that mean we do our exposure therapy at different times of the menstrual cycle? What about the military? What about women going into the military? Is there a particular oral contraceptive they should be taking that doesn't impact on estradiol, so it's progesterone-only pill, and is that going to, protect them somewhat? These are all questions.
Interesting. Pankaj, your burning questions.
Actually, I guess looking from I used to be a clinician many years ago, briefly. So if we think about what's happened in the management of cardiovascular disorders and blood-borne tumours like leukemias, things are very different from the day when I was a medical student. So the dramatic improvement in therapy has really come from the very deep understanding we have of the biology that underpins both those disorders. So we have a great understanding of the cardiovascular system and also of blood, basically exactly what happens in the white blood cells and how they perform. Now, fear, of course, is a circuit which is very similar in us and animals. And I really feel that, look, understanding the biology that underpins the generation of fear and the storage. We talk about fear, thinking about, look, so what exactly is it? What does storage of memory mean? And under which conditions is it stored? Now, we heard about extinction, and we know from the animal studies and human studies that extinction is not an erasure of their old memory. We know it's just you learning something that used to be dangerous, not dangerous. And these kinds of things will be worked out from the basic science, and the imaging coupled with the animal experiments will figure out the circuits that underpin it. And I think we will be able to target these disorders using, I guess I call them rationally based therapies, which whether they are behavioral therapies or whether they are pharmacotherapy or a mixture of the two, and they'll come from understanding the biology. And I think the fear system is one we will figure out, in the next 5, 10, 15 years.
Great. Muireann.
Well, my question actually is informed by my trying to teach my son, who's 4, about the brain and memory, because I'm like, you're never too young to learn about science. But he can grasp that your brain is in your head, and his take on it is that your brain makes memories, and you use a telescope to look at the brain. And I'm like, okay, that's pretty good. But then he asked me, where are the memories? And at that point, I actually can't answer the question. So I was sort of like, stop asking questions. But that's what I think Pankaj has referred to earlier. It's that we still don't actually know where the memories are. We don't know what different regions in the brain are doing or what they're actually saying or communicating to each other. And a lot of the work has been done looking at, for example, the hippocampus and how it communicates with, as Kim was saying, the ventromedial prefrontal cortex. But I'm actually quite excited to discover what regions in the more posterior or back of the brain are doing in relation to memory and the visual and spatial aspects of memory. And notably that these regions are the ones that seem to be most vulnerable early on in the dementia, Alzheimer's disease trajectory, and seem to be more prone to amyloid deposition. So I really would love to know, how are these regions communicating with each other, and why are they so vulnerable? Why is the peak of our memory expression so vulnerable in these neurodegenerative conditions?
Interesting. Fantastic. Well, I'm sure you'll all agree, audience, it's been fascinating discussion and so much food for thought for future research in the way we manage our memories and our fears. So please join me in thanking our very articulate and inspiring panel. We wish you all the best in your pursuits.